terms of the treatment for this patient, my general view is that if a patient has a molecular target identified, then I use that molecularly targeted therapy as the first line. In general, molecularly targeted therapies such as dabrafenib and trametinib for BRAF V600E mutated non-small cell lung cancer are associated with a much higher response rate than any other treatment which we could consider in this setting. And so I really think that it is appropriate to use targeted therapy as your first line approach if you have a target there. When you have a patient with a molecular driver alteration who presents with metastatic disease, there are really three options of treatment that you can give to that person. You can give them the targeted therapy, and then depending upon their PD-L1 staining, you can either give them immunotherapy alone if they have PD-L1 greater than 50%, or histology-appropriate chemoimmunotherapy. And in this setting, given the fact that we're talking about molecularly targetable alterations, many of these are non-squamous, so we're talking about either carboplatin pemetrexed pembrolizumab, carboplatin paclitaxel bevacizumab atezolizumab, or carboplatin nanoparticle albumin-bound paclitaxel and atezolizumab. In my practice, that's generally a very easy choice, because if we look at the data from those immunotherapy and chemoimmunotherapy trials, most patients with a molecular driver alteration, now this is specifically patients with EGFR mutation and ALK translocation, were excluded. We don't have data on the BRAF status of patients in these trials. But given the relative scarcity of these alterations in non-small cell lung cancer, that is a real lack of data. And to know how to apply those immunotherapy studies to patients with a molecular driver alteration requires a real extrapolation. The only data that we have in this space comes from the immunotarget cohort, which is a multinational registry study, retrospective, that was done of patients with molecular driver alterations receiving immunotherapy alone, not chemoimmunotherapy, and largely in later lines of treatment. What we found in that study was that immunotherapy can have efficacy in BRAF mutant non-small cell lung cancer, but it's not always the case. Another important thing which we do need to remember when we're talking about BRAF V600E mutant non-small cell lung cancer is that other types of BRAF mutations can occur in non-small cell lung cancer. So when you get that next generation sequencing report back, if it has any other BRAF mutation other than V600E, you have to be very, very hesitant about using targeted therapy, because in contrast to what I was saying about having a legitimate target and using your targeted therapy in that space, you are very unlikely to benefit a person with non-V600 non-small cell lung cancer by giving them targeted therapy. And in fact, you're delaying what are likely more effective therapies in that setting. So it really does require a thoughtful interpretation of the next generation sequencing report.